right, we are live. Good afternoon, everybody. All right. Stand by. All right, we are live.
Are you muted on your side? You are now. Okay, cool. All right, we've got just a very few people. It is Tuesday, September 1st. Is that possible? Wow. All right, so we give you just a minute or two. There's only a few people here so far, so we'll let it see if anybody comes in. Hello, Dave. Hello, George. Good afternoon. So what I'll do is just start out with the usual updates. Then I'll ask a question and of the people that are here, the few that are, and then we'll take any questions. And we do not have any guests today, so I think this will be a pretty short one. So I will start with this guy. All right, so here's our case numbers. As you can see, we continue to trend down. We do have some sort of weekly variations, which we're continuing to see. Schools are, as everybody knows, back in session, which means that they're going to be up to 70,000 people back into congregate environments. Question has come up, how long should we wait to expect to see the result of any result of school openings? And I think the likely answer is 3 to 4 weeks, just as it took 3 to 4 weeks after Memorial Day and those openings up. I'd like to offer one sort of analogy here, maybe. So I know a lot of people are wondering, when can we stop the masking and when can we reopen everything and all that kind of stuff? And what I would say is, who here has ever taken care of a patient and asked that patient, what medical problems do you have? And the patient says none. And then you say, yes, but it says here that you take medicine for your blood pressure. And they say, oh, well, yeah, that I take medicine for it, so it's fine now. So the analogy is, we're doing all the things that we need to do to keep this virus relatively in check and hold it at bay. And that does not mean that it's necessarily time to stop taking that medicine, but that medicine is working. I guess the other analogy would be, when you take a course of antibiotics, you don't stop taking the antibiotics the minute you start feeling better. You continue and take the full course until you've really completely killed the bug. And so I think we're in that sort of a situation where we've got ourselves down to a more reasonable level. We've sort of seemed to have come down the backside of this spike over the last 2 months, but I think it is important to remember that we haven't even gotten to as low a level as we were before that spike. So we are in some sense plateaued out at a little higher level than we were before. And so while I know we are all extremely tired of this, I don't think that we're at a point where we can just say, okay, it's done, we've won. I also would urge a little bit of caution in terms of, history repeating itself. We all had this sense earlier this spring that maybe we had done the stay at home and we had success and all of that. And then, as soon as we backed off a little bit, people, went back to more normal activities. We immediately saw increasing cases and eventually that huge spike. So I guess I would just urge patience and caution at this point with considerations of how long are we going to need to do these things that we're doing, knowing that the things that we're doing to keep this virus in check are in general not a whole heck of a lot of fun. So that's where I think we probably are right now. I was on a call earlier today with Dr. Osterholm, who some of you know I sometimes reference. He has that website called CIDRAP, the Center for Infectious Disease Research and Policy. He's the one who had been saying for the longest time we were in the third inning, maybe we're in the fourth inning. His comment today was he doesn't even know what game we're in anymore because of some of the things that are going on. And because of the way this virus, influenza this year, is acting different than normal. And because of some of the messaging that people are getting from various folks, it makes it very difficult to really appreciate where we're at and where we're going from here. And I guess the easiest thing to say is that there are still a significant number of people hospitalized in Pinellas County. I think the count today was 144 folks in the hospital here in Pinellas County with COVID. About 30 of them in the ICU and over 20 of those on ventilators. So to think that there are not still people very, very sick from this disease here in our community, I think would be incorrect. The last time we had in the 140s hospitalized was June 14th. So we have not yet gotten to pre-spike levels. So I think that's sort of where we're at, and as unfortunate as it is to have to say, I think that the foreseeable future looks like maintaining these preventative measures or these measures to keep the virus under control, and continuing to buy ourselves time for vaccine testing, et cetera. I also heard today that there's some idea that we may hear a vaccine announcement near the end of October. I think that if that happens, there will be a lot of differing opinions on whether that vaccine has had appropriate testing and study at that time. So I am somewhat concerned about any potential rush to give a vaccine an FDA approval. There was a very sort of funny analogy that I heard earlier today was, you don't have to be a very smart farmer to know that if you plant twice as many crops in your field, it doesn't mean you can harvest them in half the time. So which is not a bad analogy for what we're doing in terms of vaccine development. We are certainly throwing lots and lots of resources and trying multiple different vaccines, but that doesn't mean that some of the basic steps we have to get to happen any sooner. Some of them, sure, we might be able to expedite, but not all of them. And so stand by for that. I would tell you that it's shaping up to look like Florida will be one of the earlier states to get vaccinated. There's a strong likelihood that you all as pre-hospital clinicians will be called upon to assist in any vaccination campaigns. So I would not be surprised to see that happening, and the groundwork for that is already beginning to be set. And, you know, I think there are places in the country that are on the front side of their peak, similar to where we were 8 weeks ago. There are places in the Midwest that are now having their explosion of cases, it seems. So I think we're going to continue to see sort of peaks and valleys in various places around the country. But I don't think any of us should be under any illusion that we're not going to be with this for quite a while longer, as unfortunate as that is. So any questions on where we are, the general updates, et cetera? And while I'm waiting for the delay to catch up and people to type their questions, I'll ask one question back to the group, which is, do you believe that there is some confusion between what criteria cause you to put on your full PPE and what criteria cause you to adjust your clinical treatment according to the yellow placard? Jasmine, I sent that one to you. Did you get a chance to read it?
About confusion?
the thing that one of our lieutenants came up with, that training scenario I sent you. Your blank stare says you haven't seen it yet.
Oh, I'm trying to remember. I've been through a lot of emails, but I probably have. I'm going to look real quick.
So here's the example. The example is you have a patient with COPD and they have shortness of breath and you want to give a neb, and because you're doing a aerosolizing procedure, you put on your full PPE ensemble. But just because you put on that PPE ensemble, does that mean that you also hold off on the Solumedrol? So I see you shaking your head no. We've had this come up a little bit, so I just wanted some feedback from the other.
I definitely had that come up a few times. I was just looking at that email. I just pulled it up. Yeah, so I've actually talked about this a few times, I think here and with people in the classroom and out in the field. So if there is still confusion about this, I don't know. Sometimes I think there's a little confusion. I think a lot of it's just fatigue from being out there and doing this, that people are just getting a little bit more relaxed. But in general, I think we've been over, like, if they meet any of the criteria, you're always going to protect yourself. And obviously you're going to do a full assessment and differential diagnosis. And when you decide this is probably caused by COPD or asthma, then you're going to treat that way. And if you think it's possible COVID, then you're going to withhold.
Sounds about right to me. Okay, take a look at that thing I sent you and see if you think it's helpful to distribute, though. All right, I don't see much else except for the discussion about Solumedrol in the comments here. So with that, I'll move on to the next thing that I wanted to share, which is that I believe we are very, very close to having a true antibody testing offering for the entire system, which is voluntary, but will be a high quality, reliable test based on an actual blood draw, not a finger stick. And so I really hope, I know there's been a lot of delay and a lot of obstacles, but I do believe that we're going to be able to, within the next 2 weeks or so, offer that to the entire system. So I hope people will take advantage of the opportunity to have a free test so that they can know a little bit more about their own risk. That being said, we still don't know exactly how to interpret those results, particularly given the fact that we are now seeing possibly more evidence of the ability for reinfection to occur or for immunity to wane over time, which is troublesome to say the least.
So I think that's exciting. I think a lot of people have been wanting that test.
Yeah, so just to be clear, it'll be a actual needle stick blood draw, a single tube of blood, and then we will send it to the hospital lab and have it run on the fancy machine instead of a finger stick machine, and get a result that I think we can count on. And I guess thank you very much to the county leadership for agreeing to foot the bill for that for us. So expect to have more details on that by the end of this week.
Great. I want to go back to the Solumedrol thing since we've been over this. Where do you think, I see Dave Young commented, where do you think the confusion is? So I was addressing it more from PPE. So I was seeing that people were saying, hey, this person has asthma, COPD, we're not going to get dressed out and we're going to treat this as asthma, COPD, and we're going to give the Solumedrol. And then if they go, okay, we are dressing out, then we're not going to give the Solumedrol. And I think that maybe the disconnect is there, that it, just because you dress out because they fail that 6-foot standoff, that you can still go down the path that is asthma, COPD and give that Solumedrol. So I guess maybe the confusion is in that if you're dressing out, you can't treat the patient like a COPD or asthma patient.
Yeah, I think that's what it is. And I think it's separating the steps that you take to protect yourself versus any changes you would make in your treatment algorithms to the patient. And those are really two different it's a term I sometimes use that people sometimes don't get, but it's two different indexes of suspicion, right? So I have a very low threshold for protecting myself, right? And I have maybe a different threshold for deciding in my mind that I'm treating somebody according to the fact that I think they have a certain condition. And so it would be reasonable to take steps to protect yourself, even if you don't have that as high a suspicion
Right.
for somebody having COVID, because we know that people can have lots of different kinds of symptoms or even be asymptomatic. So if there's something that you're doing that's high risk or that triggers you to protect yourself, that's one sort of level. And then there's probably a second level that's maybe a little bit higher that says, you know what, I really think that this is a COVID case, and therefore I'm going to implement the yellow placard treatment steps.
Right. I guess we just push that out again. So wear your PPE if they fail the 6-foot standoff, but you can still treat them.
Yeah.
And I think lack of treatment because of COVID, I think we never went from yellow to red. So
Thank goodness.
we just reiterate the fact that we do not want to delay or change or the level of care because COVID's out there. We just want to make sure we're protecting ourselves.
Yeah. I mean, just to throw it out there, I had yet another patient last week that I saw in the ER for something completely different, who ended up coming back positive because now they screen everybody who gets admitted to the hospital.
Right.
And boy, was I glad that while I was in this patient's room for a solid 45 minutes doing an emergency surgical procedure, I was pretty glad that I had my PPE on when the patient who was there for something completely unrelated tested positive.
Yeah, absolutely. So we're protecting ourselves, but not changing our patient care.
Yeah.
I don't believe we've talked about the 60-day N95 allowance on here at all.
Oh, okay.
So I think we can talk about that briefly. If everyone saw the medical control directive that came out, we have acquired some N95s. So for now, to give some relief through the summer heat, everyone is allowed to wear N95s if they prefer it. You can still wear your P100, but you can wear the N95 and goggles for the next, I guess we're a week into it, but it was 60 days from the time the medical control directive came out, just kind of to give everybody a little bit of a break. So that is an option for now if anybody wants to do that. So you might see the change out there. And if you haven't read the medical control directive, definitely read it. But that's why there has been a change that we have released that. So it's not like people are just bending the rules. They're allowed to wear that N95. So we have those lovely orange and white kind of duckbill N95s out there now. We're also using those in PHTLS, and they're a little bit cooler than wearing that P100 all day long. So
yeah. The other thing I would mention according to that is that there is actually another version of a goggle that's currently being checked out, and so far we're getting good feedback on it. So there may be an improved goggle offering before too long as well. I don't think it's definite yet, but I think it's potentially coming. Chief Bessler has a question.
Yeah. If you're fitted for either of the P100s and the new N95s, they have the option to wear any of them.
Yeah, I'm not sure why you wouldn't, Chief Bessler. Is there something we're missing?
He's talking about the different masks. So any of the masks that you're fitted for, if it's the P100s you were using or the new 3M ones.
He's talking about the difference between the Moldex and the 3M full fit respirator.
Right. But I'm saying that as long as they're fitted for them, you can use either one or the N95.
Yeah, unless he knows something that we don't about how the deployment strategy for those was going. Both of them are somewhat limited quantities. So I think there may be another piece to that, unless we are missing something.
Well, I think that everyone, I don't want to say it, should have their own at this point, but I know that certain agencies have issued them at least.
Yeah. I would suggest Chief Bessler checks in with protocol and equipment coordinator on that specific question. Okay, here's another one. How can you tell the difference between true COPD and CHF without COVID if everyone has different symptoms and presents different? And that is kind of the point, is that you can't necessarily tell the difference. So protect yourself. The reason why we're saying maybe have a different threshold for withholding the steroids or whatever it is because the steroids are not nearly as big a deal one way or the other as protecting you is. Protecting you is the biggest deal. The steroids, we initially had data that steroids could be harmful. I think more data now suggests that that's not true, particularly in hospitalized or hypoxic patients, specifically hypoxic patients. But, you know, again, steroids take some time, hours at least, to work. So deferring that decision to the hospital if we truly suspect that it's COVID is reasonable. But I guess what I'm trying to say to answer your question is precisely because you can't necessarily tell the difference is why you might protect yourself out of an abundance of caution without having or being convinced that you need to go down the COVID treatment adjustments.
And the other side of that is, if you are protecting yourself and you are suspecting COVID, when would you treat with the salumedrol? I think that when you're doing a differential diagnosis on your patient and you're thinking like, is this COVID? Is this COPD? Is this CHF? You're really just going to go back and say like, is this a new onset? Are they sick? Have they had a fever? Obviously it could be COVID. But if they have a history of COPD and they take those medications and this is similar based on the history that you gather to what they normally have when they have a bad, flare up, then you would go down that road.
Yeah. Clinician's judgment.
Right. But if they have the fever or if they've been around someone with COVID, I mean, if any of those things are going on, you can, go down that route instead and withhold.
So I'm not sure who test 1, 2, 3 is, but hopefully that answered your question. Let us know if it did or didn't.
Get a good history. I think that is going to make a difference.
Mm-hmm. All right. Other questions? We'll give it a minute. And so I'll ask a question while we're waiting for other people to ask their questions. And my question is everybody still okay with shooting for roughly every other week with these sessions? Speak if you think they should be more or less frequent or canceled or what. All right, Dave, can you be a little more specific as to yes to what?
Every
2 weeks. Okay. Hopefully that's what they mean as well. STS, N95, and face shield. So yeah, that is acceptable if you can't wear goggles due to the glasses. I would say though that the newer goggles that we're looking at will likely, oh, he said if you don't wear glasses. Well, I was gonna say the newer goggles we're looking at, I can fit over my glasses. So that answers that. Dusty, I can't say that the face shield would necessarily give you as much protection as the goggles, but it is currently an acceptable alternative per protocol.
So the preference is N95 and goggles or P100?
Yeah, I think, so for me personally, I was in a face shield over my glasses for a while, but now I'm more moving towards the goggles. Now that I have goggles that will fit over my glasses. So that's me personally. And I don't know how to give you any better advice than what makes me comfortable when I'm seeing patients.
I think keeping this going monthly after this, it's as long as people are still jumping on here and asking questions and this stays active is a good idea, especially for making any major changes in the system. So there's some open forum for people to communicate. So I agree that this could be good, but we need people to keep tuning in. So if it's becoming too much, then, we can slow it down a little bit. Because we want people to log in here and use this as a resource.
Yeah, so we still had almost 600 views on the last one we did, Jasmine. So I think we'll continue with the every other week type for right now.
Yeah, Dave Young was asking if when the pandemic, like when all the COVID stuff slows down, if we can continue this once a month.
Oh yeah, for sure.
So I was thinking, yeah, we could probably do that at that point.
As long as that's what you guys want, you know, I don't want to sit here and do this just for my own fun. It's you know, if it's useful to you guys, we'll spend the time and effort to do it. So Chief Bessler points out that there are in fact studies that show that viral transmission through the eyes. It's true. There was a recent study that came out that looked at contact tracers. I believe it was from India, who initially went with masks without eye protection and had significant rates of infection. And once they added eye protection, they had no more infections. Is the Reader's Digest version. So yes, eye protection is important. Some people I think have estimated like 10% of infections come through the eye, but I don't have the reference to that in front of me, but I think that's the number I remember. A lot of times that may be coughing or somebody coughs on you and then you touch your eye. But okay, let's see. Anything else? Any other questions? We're up to almost 30 in the room. So for those of you who are just joining, we've gone through the general updates that we normally do. We've talked through a couple different questions, but we are at this point in an open question session. So if you're just joining and you've got a question or a comment that you want to put up, please go right ahead and chime in.
Quiet bunch today.
I know, everybody's tired. I get it, I do. All right, well, I'm not sure if Dr. Smith must be here because he's texting me, so he's lurking in the chat room. That's what I think.
So I'll talk about CME if anybody doesn't have any questions.
Because otherwise I'm going to put on some AC/DC for...
I don't know which one's more painful, CME or music. PHTLS is going. So if you haven't done your August paramedics, if you haven't done your August CME, you need to do that and print out your certificate and bring it with you to PHTLS class. That acts as your pretest. And for EMTs, today, your EMT CME for September was released. So you have 30-day timer on that, and that is now out. And that's BLS treatment and assessment through using the BLS bag. So yes, AC/DC.
I can't play it much because we'll get demonetized, right?
Yeah.
Isn't that, or no, what do they call it? A copyright violation, right? On YouTube?
They pull you down for that. I have to put little codes at the end of our videos to fix that.
Yeah. Chief Meisner, yes, we expect to have an instruction packet hopefully out by the end of this week is our goal. And it will have all of the details along with the forms and all that stuff that you'll need to do to get the testing done. Oh, good question. Demonized. That was demonetized, Chief Bessler. Get with the times, would you? Dusty says, have you heard of the actual death toll of COVID, the current news thing going around? Yeah, I've seen the current news thing going around.
Interpretation of data.
My response to that is sort of similar to my response when we see the stuff in the news about the DOH numbers for testing. The DOH numbers are the best we've got, but you know, I'm looking at hospitalizations, ICU folks, and deaths honestly as sort of the final or primary outcome. for what level of burden this is causing. And in fact, in relation to the discussion about deaths being either attributed to COVID or deaths that occurred while somebody had COVID, that's a little bit of a complicated deal. So most of you have probably never filled out a death certificate as the doctor who is saying this person died. And you actually have to fill out what is the cause of death and then contributing factors. So a good example that they used to tell us was, the cause of death. Sometimes they hated when you would write this, but or they did actually. So you're not supposed to say the cause of death was cardiopulmonary arrest, because that's kind of like, oh yeah, no kidding. So for example, if we had the cause of death be a myocardial infarction, right, the contributing factors would be atherosclerotic heart disease, dyslipidemia, diabetes, and tobacco use. Right, so all of those things would be listed as contributing causes, where the actual cause of death would be myocardial infarction.
But they're not. But you can't say they didn't have a myocardial infarction because they had those other things. I think
right. So the difference between the proximate cause of death and the contributing factors sometimes can be semantics. Right. And what I would say is that depending on what you're trying to say, what's the quote? 97% of statistics are made up on the spot. So you can make numbers say lots of different things depending on how you parse them or how you assign values to things. So what I'd say, if you really want to know, then tune into the County Board of Commissioners meeting on Thursday morning, where Dr. Thogmartin, our medical examiner, is going to directly answer those questions about how he is classifying the deaths. I've had this conversation with him, and I have every confidence that in Florida, and specifically here in Pinellas County, that Dr. Thogmartin is doing as good or better of a job than anybody else in terms of categorizing appropriately what actually is caused by COVID versus what occurs while somebody has COVID. And I've seen the spreadsheet. I've seen, what percentage of them are with COVID versus from COVID, if you want to play those semantic games. And there are decedents in both categories. So rather than me try to speak for Dr. Thogmartin on how he is applying those categories, I would suggest you hear directly from him on Thursday morning at the county board meeting. They're always recorded and always available on YouTube, etc. So, you can even ask public questions on them. So I believe he's doing a great job of doing this. And I think he's actually going above and beyond what's required of him for this. And so I'm pretty confident in the numbers he's giving us. But if you want to hear directly from him, Thursday morning would be the right time. Hopefully that answers your question, Dusty. All right, got a few more minutes. I think we'll try to end this here within the next couple of minutes, unless people decide to ask a bunch more questions. So give it just another minute or two here for anybody else to chime in. Do you have anything else, Jasmine?
No, I could ask, so I have a question to see if anybody knows the answer.
Uh-oh, are you testing them?
Yeah, yes, that's what
I was told there would be no tests today.
No tests. I just want to see who can get the question correct. What are the two major changes with trauma in our county this year with PHTLS and our March change? I'm finding that not a lot of people read our medical control directives in March as we're doing PHTLS. So
say it ain't so. They didn't read something we put out? I'm shocked.
Okay, there's three. Chief Bessler got one. That's correct. X is a big change. Now we're X, A, B, C, D. something about needle decompression. I believe this changed on March 4th. I need the
Well, it changed with the release of the 9th edition of PHTLS, but we did an interim update to protocol via medical control directive on March 4th, right?
We did. So March 4th was the official change of our decompression site. And that lines up with PHTLS.
So the preferred site for needle decompression.
We're getting there. I'm watching the chat.
Landmarks. There you go.
The needle is where? Is where? Where is the site?
Nobody wants to actually jump in and say the site. Nobody wants to go out on a limb. See, I told you, Jasmine, tests are never a good idea.
Into the chest. Okay, we're getting closer.
Chief Bessler, remind me to change your certification to administrative, yeah?
There you go. We have an instructor here that knows the answer. So it is anterior axillary in the 5th intercostal space. And that it's been that way since March. So that's a change. And I know that we're used to doing the same thing. So all the time. So I feel like you really have to know that we've made this change and you need to practice it, obviously in PHTLS, and be aware of it, because when you have a trauma code or you have a patient you're going to decompress, you need to know where that site is pretty quickly. And that's a big change for us because we've been doing it the same for so long. So yes, anterior axillary, 5th intercostal space.
Okay.
I put it out. So I would like to see everybody in PHTLS as I drop by once a day, knowing that information when they walk in the door, because we've been over that a few times. The other change is the tourniquet. Our tourniquet is now high and tight. It is no longer 2 to 3 inches above the wound. Bessler got it in 5th intercostal space. So those are our 3 big changes. Now we stop the bleeding first, and then we changed our decompression site, and our tourniquets are now high and tight. So that's the education for today.
I feel like that should be a public service announcement. The more you know.
Yeah. I felt like we needed some Jeopardy music there.
Yeah. Okay, well, if there are no other comments or questions, it does appear that Dr. Smith is lurking but doesn't want to talk. So watch, he'll say something about Cynthia, guaranteed. He'll say something about Cynthia. He likes to play a game where when we have new residents and med students, he tells them I like to be called Cynthia. It's funny. He thinks, well, let me rephrase, he thinks it's funny. All right, with that, I think we'll go ahead and wrap it up since nobody else has any other comments. And we will see you back in about 2 weeks. See, now you're catching on, Chief. So we will see you back in about 2 weeks. And if you have in the meantime a suggestion for somebody you'd like, a guest you'd like us to come on, like we did last time, please don't hesitate to send an email or let us know who you'd like to see or who you'd like to hear from. All right, with that, keep it up, stay safe. I know it's tough, I know it's tiring, I know it's hot, but stay safe. And please, 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 when you are off duty this weekend, enjoying yourself over Labor Day weekend, please do it responsibly in a socially distanced way so we don't end up with another spike like we did after our last holiday weekend. All right, thanks everybody.
Stay safe out there. We'll see you in 2 weeks.